Assisting in Cardiology Part 2 lecture. These are the following objectives we will cover in this PowerPoint presentation. Blood vessels. So there are numerous blood vessels within our body. There are two types of symptoms. There is our pulmonary system, which carries deoxygenated blood from the right ventricle to the lungs and oxygenated back to the left atrium. And then there is our systemic system, which carries blood from the left ventricle to the entire body and back to the right atrium. Arteries. The aorta is the largest artery, starting at the left ventricle and traveling through the body center to branch off into the femoral arteries in the lower abdomen down to the legs. Arteries branch off into smaller vessels, becoming arterioles. Arterioles terminate in capillaries. Only a single cell thick, so capillaries are only a single cell thick, so that nutrients and gases can pass through for exchange. Veins are deoxygenated blood that leaves the capillaries and entering into the venules. Blood flows into larger veins until it reaches the inferior or superior vena cava. The valves in the veins operate by contraction of muscles around the veins. The vena cava deposits blood into the atrium, where it begins to get pumped to the lungs for oxygenation. Veins lack the muscular lining that arteries have, so they have valves to prevent the blood from the backflow. Shock is a general collapse of the circulatory system, including reduced cardiac output, hypotension, and hypoxemia. Extreme thirstiness, restlessness, and irritability are common. The body compensates with vasoconstriction to allow blood to pool in vital organs. Vasoconstriction will cause a cool, clammy skin, pallor color, tachycardia, and decreased urinary output. If not reversed, the central nervous system becomes depressed and renal failure may occur. Start emergency treatment, so supine position, assess vital signs, keep warm, administer oxygen, and elevate legs. If symptoms progress, you will have a weak, rapid, thready pulse, tachypnea, and an altered level of consciousness. Varicose veins are dilated, tortuous, superficial veins in the legs. They are caused by either congenital defects, pregnancy, obesity, prolonged sitting or standing, and heavy lifting. Treatments for these are exercise, limit the lifting, elevating legs, using compression stockings, and sometimes surgical intervention. Sometimes varicose veins can be very painful, and it is important to be mindful of that with patients. Deep vein thrombosis. So risk factors are recent surgery and older age, trauma or obesity, oral contraceptives, varicose veins, and pregnancy. Phlebitis is an inflammation of a vein which can lead to a blood clot or thrombus forming. DVT is an inflammatory thrombus attached to a deep venous system of the legs. Pulmonary embolism occurs if a thrombus breaks loose and travels to the lungs and blocks the pulmonary artery. This can be a very dangerous situation and can kill people. Common symptoms of PE or pulmonary embolism are chest pain, unexplained shortness of breath, syncope, hemoptysis, and severe anxiety. IV anticoagulation therapy or Lovenox subcutaneous injections can prevent clots. from forming, but they cannot destroy the clots. The body needs to break down the clots in its natural processes. Patient education for DVTs: take the prescribed medications as directed. If patients are taking warfarin or Coumadin for post-surgery, they oftentimes will need to take it for 6 to 12 weeks as prophylaxis. And sometimes if a DVT is detected, they will need to take warfarin therapy for 3 to 6 months with an INR range of 2.5 to 3.5. Most INR ranges are 2.0 to 3.0. For DVT and DVT prophylaxis, we increase that just a hair to 2.5 to 3.5 for extra protection. If you have been prescribed anticoagulants, it's important to eat foods high in vitamin K in small amounts or consistent amounts, I like to say to patients. You don't want them cutting out leafy green vegetables, especially if they are a heart patient. You want them to eat these things. Avoid sitting still for long periods. Walk around several times during the day or move your legs frequently. Alter lifestyle factors such as obesity, smoking, and hypertension. And wear compression stockings as ordered by the physician. Arteriosclerosis and atherosclerosis. Treatment for these conditions is diet restriction and to stop smoking. Arteriosclerosis is the general term for thickening or loss of elasticity of the arterial walls associated with aging, hypertension, scleroderma, and diabetes mellitus. Atherosclerosis is a form of arteriosclerosis marked by the formation of atheromas along the inside of the vessels. Buildup of cholesterol, cellular debris, and platelets all play a part. Aneurysms, ballooning and dilation of blood vessel walls due to genetics or buildup of arteriosclerotic plaques. If rupture, surgery intervention is needed immediately. Oftentimes, if an aneurysm erupts, especially an aortic aneurysm, those patients do not survive an event like that. Diagnosed by hearing turbulent blood flow sounds, radiologic studies, ultrasound, or CT. Surgical repair to prevent bursting often is common. We often auscultate the bruits that are often heard for abdominal aneurysms. And then if a bruit is heard, then we will order other studies such as a CT scan or MRI to see how large that abdominal aortic aneurysm is. Surgical repair will prevent the bursting. Peripheral artery disease develops because of a widespread atherosclerotic plaque buildup. So not only can the plaque build up in your heart and cause an MI, it can also build up in your legs and cause ischemia in your legs and tissue damage, and this is how people lose their foot or their lower leg and have to be amputated. Reduces the amount of oxygenated blood delivered to the tissue, causing leg pains, numbness and weakness, and cold extremities. Soreness of the feet and legs and hair loss on the extremities are the first signs. Treatments include exercise, smoking cessation. They can also stent the blockage that is present. And they can also bypass the blockage that is present if it's a major artery in the legs. Cardiovascular examination is mainly subjective to symptoms, which is a large part of the exam, so that general interview is very, very important. General appearance, skin color, symmetry, clubbing fingers, jugular distension, Temperature of extremities and breathing patterns are all important to note in that general physical exam. And then recording those symptoms that the patient reports. Chest pain, shortness of breath, pain between the shoulder blades, pain down the arm, retaining water, those sorts of things. A complete list of prescriptions and over-the-counter medications is important to take as a medical assistant. That is part of our job. And then the physician will do the physical examination that covers the chest, heart, and vascular system. Electrocardiogram and Holter monitors. An ECG records the electrical activity of the heart. A Holter monitor may be ordered for the patient to wear over a 24-hour period. If we do not catch the palpitation or arrhythmia on an EKG, sometimes we will order these types of tests. And then if a patient is ordered to have a Holter monitor, it is important for them to record the symptoms when they are having them so we can correlate with the rhythm strips that we get back. Doppler studies are used to identify occlusions of both veins and arteries. Sonographic beam picks up the speed of the red blood cells as they travel through the vessels. Physicians will listen to a change in the pitch that is often given off by the Doppler to evaluate the blood flow. Angiography is where we shoot an X-ray while we administer dye into the coronary arteries. Usually a catheter is inserted into the femoral artery, which is in the groin. Now we are moving more towards less invasive catheter insertions in the radial and brachial arteries in the arm. However, patients do need a certain caliber of artery in order for us to use them because we do not want to block off all blood flow to the hands. So here shows a picture of an angiography image. This is the left main and it looks like there is a blockage almost completely blocked off. There's a little blood flow going through there. The white is the blood flow going through. Here I would say this is about an 80% blockage of the left anterior descending artery. And then we also have the circumflex artery which is branching off here. Echocardiography is an ultrasound of the heart. We mainly do echoes to evaluate the valves and the pumping function and to evaluate the muscle of the heart and how it functions. We typically don't do an echocardiogram to evaluate the coronary arteries. That is what our angiography is for, is to evaluate those coronary arteries and if there is a blockage. Cardiac catheterization. A cardiac catheterization or angiography is used to diagnose or evaluate a variety of heart disorders. So heart catheterization can not only diagnose our blockages in the heart and our coronary arteries through our angiography, but it can also evaluate the valves and the valve pressure and the amount of pressure that the heart is creating when it pumps that blood out of the heart. So cardiac catheterization can diagnose a plethora of heart disorders. Once the catheter has reached the desired position, we will then administer the contrast medium and it is injected, and fluoroscopy, aka X-ray, is used to visualize the heart chambers, valves, and coronary arteries. Angioplasty, if there is atherosclerotic plaque, like I showed you in a couple of slides previous, are discovered. to be occluding the coronary artery or 70% or more of the artery, a PTCA or percutaneous coronary angioplasty may be performed. Goals of the angioplasty are to restore complete blood flow to the ischemic myocardial tissue and reduce the need for cardiac medications. It also eliminates or reduces the number of episodes of angina or chest pain. A balloon that surrounds the upper portion of the catheter is collapsed and inserted into the artery, and once it reaches the point of where the blockage is, the balloon will then be inflated and push the plaques to the outside of the artery. And then what will happen is the physician will then slip the stent in there, in that stretch of where that narrowing was. And then the balloon is then taken out, and the catheter is taken out, and the blood flow is restored. Cardiac pacemakers are used for the electrical system when the heart is not beating. It generates an electrical impulse. A lot of times these are given to patients with bradycardia, complete heart block. Oftentimes pauses are seen on the EKG or Holter monitor with unexplained reasons, so there is no blockage in the heart that we know of that could be causing disturbances to the electrical impulses. So the pacemaker is usually always placed in the patient's left upper chest. The wires are then fed through the left subclavian vein into the superior vena cava, and then they stimulate that SA node, and then one of the leads is down into the ventricle, which will stimulate and pace that heart rhythm. Some people are completely dependent on pacemakers. There is no electrical stimulation of the SA or AV nodes, so the battery life obviously is a lot less. However, some people only occasionally need a pacemaker. Their heart will sometimes give electrical impulses, and then sometimes it will say, I'm on vacation and I need help, and that's when the pacemaker will kick on and help that heart pump and give it that electrical stimulation that it needs. Those patients who only need the pacemakers occasionally, the pacemaker battery life can be up to 10 years. It is important to note that those patients that are dependent on pacemakers, if their battery is end of life, they need to be replaced right away, not a month from now. Those who are not dependent can wait a little bit longer to have those replaced. Implantable cardioverter defibrillators, we often call them ICDs or just defibrillators. These are for patients that are at risk of sudden death from cardiac arrest. Generally, patients with less than 30% of an ejection fraction on an echocardiogram 3 months after they've had any stent or bypass are eligible for an ICD or defibrillator. Most CHF patients or congestive heart failure patients have this. Cell phone, they're usually the size of a small cell phone. Is implanted in the chest, similar to the pacemaker, under the skin, and is attached to the heart with small wires. They can be either single chamber or dual chamber, and they are designed to deliver a measured electrical shock to the myocardium if a life-threatening arrhythmia occurs, such as ventricular fibrillation. It is important to educate patients to stay away from magnets, chainsaws, welders, electrical generators, and microwaves. They cannot have electrocautery to stop bleeding, and they cannot have MRI scans with defibrillators. It is also to note that pacemaker patients can also not have MRIs. So patients need to stay away from these things when they have an ICD, or they will receive a shock or multiple shocks until they quit that activity. It's important to provide encouragement and support by using community resources to help patients find assistance with these changes. A lot of patients that are truck drivers cannot obtain a CDL with an ICD or pacemaker for safety purposes. Provide pictures, brochures, and pamphlets to help patients learn, and document patient education intervention. It is also important to educate patients that they will need to have their devices checked every 3 to 6 months after they have their initial follow-up after it being placed, to check to see if there are any events or any adjustments that need to be done. Legal and ethical issues. You assume responsibility for the accuracy and precision of the diagnostic procedure that you perform. And that concludes part 2 of Assisting in Cardiology lecture.